And I had said good morning to Amanda, but she reminded me it's not morning everywhere and that the world doesn't revolve around Robbie and Reza. So good afternoon, good evening, good night, wherever you are. Luckily, we do have a case presenter today. Joy, I was hoping that before Robbie kicks us off with the discussion for their first aliquot, Joy, maybe you can just unmute yourself, do a bit of an intro, and then I would love to hear from Amanda, who is scribing, and Deborah, who is teaching as well, to just tell us an update about your lives and how things are going.
Yeah, I'm not sure. Oh wait. Yeah, can you all see me, hear me? Okay, so I I'm very interested in the brain, obviously, and I'm actually applying, and this for this season March, yeah, it's already almost closing, and I did my medical education in the Philippines. We're originally from the Philippines, and for undergrad, I did some neuroscience with Harvard, so a program there. So yeah, happy to be here, and I'm a huge fan of Ravi and Reza. I mean, I, I'm so blown away by what they're doing with democratizing, the teaching stuff. Like, it's like a dream of mine. Like, I mean, I didn't know it could happen. Like attendings with this much knowledge and accomplishment, they just give it away. You know, my experience previously is like it's like not at all like at the other end of the spectrum. So I'm very thankful for this opportunity that they have for learners like me.
And Joy, we're very thankful for you, and thank you for being here and presenting the case. I actually worked in Saipan for a couple of months in the Northern Mariana Islands, and there was a lot of people from Philippines who were practicing there. But Amanda, say hi, please.
Good afternoon,
Oh, yes, good
everyone.
afternoon.
How are you
How was
guys?
your run today?
It's very, very good. Here it's hot and cold, you know, and when this season it's like that I love to run, and it was a good runner today. 4 km. It's a record.
Wow.
It's a super record today.
Congrats. Deborah, hello, how are you?
Hi, I just did my exercise too, got back from CrossFit, and yeah, I'm doing good, excited for the year and full of motivation and plans, and that's it. I think we can start with the case.
Well, thank you so much for being here. And Robbie, let's hear a couple. Oh, he turned his head. Joy, whenever you're ready, start presenting the case and we'll go to the whiteboard. And Robbie's actually in the ED, so if he gets busy, you guys are just unfortunately left with me. His older but not smarter brother.
All right, so we have for us today a 33-year-old gentleman. He is a veteran of the Air Force. He's coming in for episodes of blanking out. 33-year-old. So do you want more history, Reza? Or
yeah, up to you, Joy. Whatever you
so he had this the title of this would be like recurrent episodes of loss of consciousness. So he's been having this episodes of blanking out since 2016. So he blanked out so much that he doesn't know what happened when he was alone, and he fell. Like one time he fell like at 12 feet off. The most recent was in 2019, and also it recurred in 2019, and then several months ago he was driving with his family, with his wife in a car, and they were trying to find parking, and he felt this feeling of anger. Like it just came out of the blue, this anger and panicked, and he felt panicked. He didn't want to be around people, and he felt very sweaty, hot, and uncomfortable. He and his wife said that his eyes were open, but he was blanked, like unresponsive for a minute. And yeah, so I would like to stop there and hear from you guys. What do you think?
And Joy, it's incredible how much clarity we got on the syndrome that you gave us after you gave us a little bit more information. I think the place that we started were that somebody was having recurrent episodes of loss of consciousness. And I think that space is one that is something we've revisited and captured by the mnemonic of the 4 S's or 5 S's or 6 S's, depending on how many things you want to include in your first pass workup. But in terms of somebody passing out, I think 3 S's are the most important to think about acutely, which is this is a person having a syncope, seizure, and then sugar or deficiency in sugar. The other S's are a little bit less important, but include substances. So opiate intoxication is the best example, stroke or TIA in the right spot, and then last but not least, sleep, falling asleep. And so here, I think the interesting thing to reflect on is maybe not so much about when the patient gets sick, but something else. And that is the patient gets so sick that he passes out, but for many years, he's fine between episodes. So, you could study this graph in 2 different ways, and I'll describe the patient. He's doing well, passes out, doing well, passes out, doing well. And you'll get just as much information from understanding why he passes out as you do from understanding why he's normal in the middle. So this phenomenon called the inter-episodic period, the period between episodes, is as informative as the episodes itself. So I'll pass the mic to the Professor to reflect on the episodes itself, but I'm inclined to think that the fact that he is normal in between them is very, very indicative of a couple of subtle phenomena. So how could somebody have such devastation and be completely normal in the middle, in between them? And the most common answer for loss of consciousness is that they had a sudden discharge of electrical activity. So they had a zap either in their brain in the form of a seizure or in the heart in the form of arrhythmia. And that zap was temporary and it didn't come back. Epilepsy is a great example. Having episodes of ventricular tachycardia, like from Brugada or from long QTC syndrome, is another great example. There are other things that can also happen temporarily and not have any inter-episode symptoms. And those are when a specific molecule comes in, does something, and goes away. And that specific molecule can be fentanyl, or that specific molecule can be insulin, causing hypoglycemia, or opiates. So at the end of this case, let's reflect on how powerful it was to assume that this person was normal between these episodes and how that can help us. Right now, that's an assumption. We don't know that yet, but I think Joy has given us information to think that or wonder that. So that space is very, very productive and is as helpful as studying the episode itself. But I'm curious what Professor has to say in general, and then how the episode itself is guiding his thinking.
What I have to say in general is that your approach is brilliant. I love this inter-episode period and analyzing the normal as opposed to focusing on the abnormal. I'll be very brief here. For me, I'm looking at the patient's age as a clue when I'm filtering through those 3 S's, which all can have inter-episodic normalcy, the syncope, the seizure, and the sugar. And I go a step further saying if it's a young person with something that's causing syncope, my focus would primarily be on the heart, either in the form of a congenital arrhythmia or structural abnormality like ARVD, arrhythmogenic right ventricular dysplasia. It could definitely be a seizure, but using the symptoms the patient has, the sweating just makes you think of autonomic discharge. And when someone is hypoglycemic, the sweats are an alarm to go find food, to go find sugar. So I think the lack of post-ictal period, the lack of convulsions, etc., sort of lowers but doesn't exclude seizure. I think the sweats prioritize hypoglycemia or vasovagal syncope. But vasovagal syncope, unless there's another clue that Joy shares with us, like the patient is seeing blood or something like that, is less likely. So just from this information we have, I think hypoglycemia is prioritized over the other causes. So we'll see more as Joy presents to us. We'll get more data. But the physical exam is going to be very important here, focusing on the heart, and then labs, of course. And sometimes the physical exam, if the physical exam is completely normal, I think it prioritizes a metabolic disturbance like sugar. Yeah, but we'll see what happens.
So past medical history, he has history of PTSD and lower back pain. So he had multiple deployments to Afghanistan for at least 6 months at a time. And one time he has a really severe combat accident. Like they were in a helicopter, they got shot, he fell, hit his head, lost consciousness. And there was also a blast injury that he suffered. So he had at least he was seen for this previously, and he had head trauma with loss of consciousness, and so that's that. And as far as like, do you have any more clarifying questions for me regarding these surrounding this episodes that he has? Or
Joy, I think I just want to make one comment and then ask one question.
Okay.
I love
Okay.
the fact that you're using loss of consciousness, because a lot of times when I'm on service, people use the term syncope. And if you use syncope, you've anchored on just one S. So using that term of transient loss of consciousness is very important. I think the audience was curious what happens after the episodes. Does he stay confused, or does he quickly alert and oriented and functioning?
Yeah, he does have he's confused and disoriented. Yeah, he does have post-ictal, yes. But you accurately caught that he doesn't have the convulsions or any abnormal motor activity during. And yeah. And do you want me to continue? The physical exam, we saw this guy at the clinic, so he was pretty normal. The exams were normal, so that's that for the exam. Yeah.
And then Joy, maybe before you go into more data, Robbie and I can sort of
Yes.
pretend that we were in clinic and this patient presented with this story. And
Mhm.
Robbie, I'll share my thoughts and then would love for you to layer on if this patient came to your urgent care in the emergency department. And my thoughts is that the normal physical exam just further supports this idea of a disease entity that has bursts and then normalcy, bursts and then normalcy. So right away, I want to capture what happens during the burst, So what I'm doing for this patient and the family members is I'm giving them a blood pressure cuff and I'm giving them one of these. Well, I'm not giving it to them. They're paying for it themselves. But what I would like them to have is one of these. Basically, this tells you what the heart rate is and what the pulse ox is. So I say, when you're feeling you're going to have this episode, put it on, check your blood pressure. And I'm doing one more thing, a point of care glucose. Like in the ideal world, I want to know what is the glucose, what is the heart rate, and what is the blood pressure. And that would be like sort of my next steps. If I don't hear any kind of murmur, if the cardiac, I think an echo is very low yield in such an individual. I know some people would order it, but I don't think it's necessarily indicated. And I'm not yet ready to put like a Holter or a Zio patch necessarily yet, though cardiac arrhythmia is definitely a possibility. Pass the mic to you, my friend, to see what your thoughts are here.
I think that this is an expertly presented case, Joy. I think you're doing such a marvelous job helping us dissect this, and I think it's really cool to see now more and more evidence that the inter-episode period is that without a trace of the disease process. And I think the patient saying that he's fine between episodes is great, and then you also observing that he's fine between episodes is great. So my advice from this case is to not copy what I used to do, which is to be a little bit frustrated that I could not see the disease right before me. Instead, use his complete normalcy as a very powerful clue. And I'll try to be a little bit more specific about what it tells you. Whatever this disease is, you're going to need either imaging, blood work, or studying his electrical activity to find the answer. So either an MRI or an echo, blood work looking at sugar, or an EKG or an EEG. And I think that if you're trying to make an educated guess about which test to use, say because you're working in a low resource setting, is the probability of an image positive disease, be it an echo or an MRI, reduces significantly in the face of your normal evaluation. So the answers to these loss of consciousness cases are almost always unfolded by the E's, EKG or EEG, by blood work, sugar, or by pictures of the brain or the heart. When the exam is normal, as is done, there's a probability that it's falsely normal. But the more confident you are that you were able to do a decent exam, the more you should invest in your E's and your blood work. So as Prof. Rez emphasized, a metabolic cause is very important, and hopefully the lab will be helpful. But I think this is the case where the EKG and the EEG might be of more value, at least initially.
So
Love it. Just to dance a little with you, I think the EKG, maybe you might find something like slight ST segment changes in like V1, typical of like Brugada on the baseline EKG. But I think the EEG will probably be of low yield right now. Like the patient is totally normal. You're capturing the normal period. So unless the patient has another event, goes to the hospital and gets an EEG, then you may. So I think all you really can do and you wouldn't necessarily send it. I don't think I would necessarily send this patient to the hospital right now because they're totally normal, but I would get a baseline EKG based on everything. Would you get an EEG at this point?
Yeah, I actually have to deal with that question right now in bed 8 about a patient who might need it. And I think you're 100% right. The value of studying the electrical activity in the brain or the heart is much higher when the patient's experiencing an event. But for both the heart and the brain, the yield of inter-episode study is not zero. You can see, like you said, you can see evidence of Brugada. Sometimes you can see episodes of focal slowing or of an epileptic focus without there having a seizure. So yeah, I mean, if you're trying to prioritize which one, when to get it, I definitely think that getting it in the middle of the episode is way more helpful. 100%. All right, Joy, mic to you, please.
okay, so this has been progressing after the incident with the car with his wife. So he's been having this spells, this blinking out every other day. And the last one was the previous day when he was staying at our clinic, which he described as, this has nothing to do with position or anything like that. It could happen while he was lying down, sitting. And he went to his PCP and they did a thorough cardiac evaluation and he was okay there, and that's why he came to us. And so he did log these episodes and he couldn't find any trigger at all. So so as far as the cardiac workup, we're all negative. And so like I said, he has post-ictal, and So he also thinks that this has really worried him because like he works in a manufacturer industry, and it's really dangerous when when this episode happens, and he also is kind of really worried like he was thinking he might be going crazy because he has no control over this. So yeah, so do you want more or talk about that more, or should I continue with the diagnostics that you guys want to know?
Maybe I can just reflect briefly, and then Prof. can reflect on anything else, and the diagnostics that you give afterwards. And I think that it's very easy to say that the concomitant psychiatric symptoms that he's mapping have a very easy explanation, which is that he has PTSD from a very understandable issue. However, if there's a rapid increase in his psychiatric symptoms, I think that you might label this process as loss of consciousness, intermittent loss of consciousness with progressive psychiatric symptoms. And that, of course, evokes the idea of tilting the scales towards the brain, especially if your cardiac evaluation is becoming less and less productive. And of course, I think it's important to emphasize that seizures are really just a rapid discharge from a specific abnormal circuit. And that abnormal circuit can generalize, of course, but you can have seizures that are purely sensory, like you just have focal paresthesias in one arm. You can have seizures that are purely psychiatric. You can have seizures that are enact repetitive behaviors like walking in and out of a room stereotypically over and over and over again. So seizures are very, very interesting. They're most classically motor, but here the acceleration in the psychiatric symptoms might be a reason to focus more on his brain. All right, Joy, tell us more, please.
Yeah, this is kind of really short. He was sent for an MRI for an imaging, but he hasn't done it yet. So what was done there at the time was he was sent for an EEG, and yeah, that's would be the end of this story. So so the EEG finding where there was left temporal lateralized delta activity during sleep. So what do you think of that EEG finding?
Yeah, well, Joy, I want to make just a few comments here. If Leah is able to unmute herself, Leah, you early on in the chat mentioned temporal lobe seizure and its association with autonomic discharge. So we were using the sweats as a clue to either hypoglycemia, and I wasn't aware, or a variant of a seizure based on where the electrical focus is, to prioritize, even when you're talking about seizure, where their seizure might be located. So I would love to hear from Leah if she can unmute herself. And then the other thing I'll mention is this, like, I'm curious to know how many days after an event is a spot EEG useful as opposed to a 24-hour monitoring EEG. So in this case, it was the patient had the episode and presented pretty quickly to the clinician. So you were still within a 24-hour time frame, where I think the spot EEG, the yield might be higher. But that's something I'm going to look up after this case to educate myself, because it really does have consequences on how you guide the patient. But this confirms that that this patient's having non-convulsive seizure episodes with blank stares and post-ictal confusion. And I think giving the mic to Leah to talk about the autonomic discharge and thinking about seizure not as sort of like idiopathic, but what might be causing the seizure. And there you can really apply the missed mnemonic plus genetic etiologies. Jack Penner created a terrific illness script on CP solvers that lays that out. So Is there so even if you have hypoglycemia, it doesn't exclude the possibility of seizure, for example. Is there something structural in the brain where the MRI is helpful? Or is there some kind of genetic disposition to a primary form of seizure where it's not secondary to an organic pathology? But Leah, are you able to unmute yourself and talk a little bit about how you knew about that association? Because you quickly said the sweats makes you think of potential temporal lobe seizure.
Yeah, I don't have an expert opinion on this, or I haven't seen a patient yet with this, but it was actually by coincidence yesterday that I read about focal epilepsies. And I just remembered that temporal lobe seizures and autonomic symptoms were associated with it as well. And I think there were several people also in the chat who thought about temporal lobe seizures, but then how you discussed, okay, wait, this autonomic or the sweats makes you prioritize these two. And then I was thinking, wait, but I had just recently read maybe there was this association as well. So that's actually all I know about this. And I know that Shame also mentioned in the chat, the typical progression of temporal lobe seizures. First, you have this aura which might have olfactorial or visual symptoms, and then it progresses to motor. But then, as I read somewhere in this process, there might also be sweats or autonomic symptoms in it.
Leah, that is brilliant. Thank you so much. And it just tells you the power of, one, identifying a unique feature of a case, and then allowing that unique feature to prioritize the differential diagnosis. And if you didn't know that prior to this case, I promise you'll never forget. And so I just find medicine very fascinating when you're seeing this stuff in order to have diagnostic efficiency. Let me pass the mic to Robbie. He seems excited. Interested what he has to say.
No, the Prof. Rez, we keep saying that these things are coincidences, like, oh, I recently read about this and it showed up here, but I don't think it's coincidence anymore. These coincidences are happening too often, Leah. And I think Prof. Rez was just I don't want to, you'll see Prof. Rez's Twitter. He was on, he recently heard about a case of ALCAP a few months ago, and then just saw a case in Morning Report. And Leah, you read about temporal lobe or epilepsy yesterday, and you're seeing another case today. I think that it just goes to show the power that I think Prof. Rez keeps emphasizing, the power of reflection, being there and putting yourself in circumstances in your own head where you're thinking about things. And all of a sudden you'll see that medicine may be much simpler and much less daunting because all these things keep coming up over and over again. So it's just two examples from today, from Prof. Rez earlier with the RLR and ALCAP, and Leah today with temporal epilepsy. It really got me excited about just the power of hanging out with you all, spending time with you all, thinking about cases, then also doing it on your own time in your own head. All of you, I think, should really try to do what Prof. Rez and Leah just did, is spend just a few minutes reflecting on the things that are coming your way. And all of a sudden you may find yourself in VMR where you get to the answer above before I even thought of it. So kudos to you, Leah. That was amazing.
Dude, Robbie, it's so powerful. Think about what you did initially. You were there's inter-episodic normalcy. So it has to be a transient event. And then the sweats were well, really this prioritized, if it's syncope, it's vasovagal. It could be hypoglycemia. And if it's seizure, one that has the sweats, temporal lobe, it's just so powerful to filter. Now you look and you see, are other seizures associated with it, et cetera. But you can keep making progress from so little information. This just increases the diagnostic efficiency that one has. But Joy, let me give the mic back to you to share your thoughts as a brain expert and what feedback you have for us.
So you guys really worked. I'm amazed that you were able to pick up the two top differentials. We were thinking, Ravi pointed out this could be something psychogenic, like a psychogenic seizure, given the PTSD that he has. And you zeroing on the autonomic part, and we were definitely thinking of a left temporal lobe seizure activity for this guy, given the TBI that he had with the deployments that he had. So that's why Well, in this case, though, he doesn't have the convulsions and those things that, as far as the laboratories that we could do here for to really pick up that this is seizure, like the prolactin and the ammonia, those things, it's not really helpful here. CK is not, this is not a tonic convulsive seizure type. So we just gave him the medications for this, and given this history that he has of PTSD, what do you think would, I guess my question is, what would be the best anti-seizure for this guy? That's the other teaching point here that I'd like to bring up, because this is a good case example for such
I have no idea. I'm excited to learn. But Robbie, do you know?
Absolutely
mean-
no idea.
I'm gonna guess Keppra, but I'm probably wrong.
that's the first that's the first line that we grab for seizure, right? But then you got it. But then given the behavioral, the PTSD, this is the top side effect of Keppra. So yeah, we didn't give them Keppra. So we started him on something else, and it helped him. And so the lesson here is, one, anxiety, stress happens all the time. It's pretty ubiquitous, but then if it caused them some spells, it doesn't mean that we need to investigate. It doesn't rule out this other structural stuff that, and having PTSD, does not mean that you're immune to structural stuff happening in your brain, given your history of really some at least a moderate TBI of multiple occasions, like he has in his deployment to Afghanistan. So this is a really good teaching point for me. Lessons here, and the just quickly, historical features that raise concerns for any type of seizure activity later on would be such as we saw in this case, any form of obviously moderate severe TBI, head injury, any form of intracranial bleeds, a skull fracture, loss of consciousness, or amnesia for at least 30 minutes. Yeah, this has been implicated for a later seizure activity later on. So, and also you guys have as far as like evaluation of a spell, just important to think about what happened before, during, and after. I guess you guys we went through that. So yeah, so that's just that. I don't want to,
Joya, I just want to make one more comment, and maybe in the chat you can write what anti-epileptic medication was initiated. I know some folks are curious. The comment I'm going to make before I give the mic to Robbie is the following. There is a phenomenon known as ictal syncope, where you actually have a seizure in the brain, which increases the parasympathetic tone, causes bradycardia, which decreases cardiac output, which leads to syncope. So it's just, medicine is amazing. And although we try to put the patients in specific buckets, it's really important to know you could have seizure from hypoglycemia. You could have cardiac syncope from seizure, but that's going to be the next level of like stretching yourself and pushing yourself to know that things can overlap, and it doesn't have to necessarily be independent buckets. But Mike, to Robbie, my friend.
Oh no, I'm just basking in the wisdom of this conversation. I have nothing to add. Really cool to see. And I as I tell people here in the ER, I'm a DX doctor. I don't know how to treat anything except with fluids, diuretics, antibiotics, or sometimes even nebulizers. So Joy, I have no wisdom to offer about anti-epileptic. But maybe Deborah does, and along with her amazing teaching points.
Hi everyone, great case. Thank you, Joy. Thank you, Reza and Robbie, for the discussion. So going for our teaching points with loss of consciousness, we thought about our 6S. And as our episode of being acute, we thought about could be more syncope, seizure, and sugar. And the other 3S, substance, stroke, and sleepiness. And in this patient, as is young, a causal syncope could be something primarily in the heart or RVVV. And we thought about the sugar, and the patient presented sweating, autonomic discharge, could be an alarm for hypoglycemia. And if the physical exam is normal, we have to give priority for the sugar. And then Robbie asked how the patient gets so sick and then pass out and then gets well. That could be like a zap in the brain, as a seizure, for example, an epilepsy, or in the heart, that could be an arrhythmia. So Reza told us that in the exam, he will look for the glucose, the heart rate, and the blood pressure. And then other MRI, echo, a blood for sugar, EKG, or EEG. But as the exam was normal, Robbie said that we could prioritize more the EKG and the EEG. And then by the end, Robbie teaches us that the loss of consciousness could be progressive from the psychiatric disease of this patient. And Leah gave us the great part about the temporal lobe epilepsy that can present with autonomic symptoms and and then go for motor symptoms. So yeah, thank you everyone. It was such a great case.
Deborah, you crushed it again, my friend. Thank you for the amazing teaching. Joy, thank you for joining us today. And Amanda, thank you for scribing.
Thank you. Thank you.
I hope you all have a lovely day, full of exercise and good times. Until next time, this has been Robbie and Reza, RLR.